Good afternoon, everyone, and welcome to our Protect Our Province pop-up briefing for Alberta. We are live streaming from the traditional and ancestral territory of many peoples. We are grateful to live and work in Alberta, a province on the traditional territory of 48 different First Nations and the unceded homeland of the Métis Nation. Today's conversation is not being shared in ASL, but to ensure completely accurate access to information, closed captioning will be uploaded after the live stream is complete. This conversation for the public is being shared live on YouTube, X, formerly known as Twitter, and Facebook. The views of our panelists are their own and do not represent any institutions they may be affiliated with. We have collectively gathered here as concerned Albertans, attempting to ensure that everyone in the province has access to as much information concerning the current state of our healthcare system. Hello, everyone, and welcome back. Thank you so very much for joining us in this final of our series of 3 pop-up briefings for this time around. It has been a pleasure to get to spend the last 3 weeks with Albertans. I've missed you all a lot, and hearing from everybody over the last month has been really heartening while we continue to go through so much trauma, from what is happening in our system to what is happening to our fellow citizens to what is going on in many people's homes right now as COVID-19 continues to spike in the province. I have our weather report, as is our tradition. This week, I printed it, so I cannot have the computer glitches of last week. So ideally, technical difficulties will be avoided. So what we know this week, Tara Moriarty's COVID hazard index level has us as severe again, estimating that 1 in 14 Albertans currently has COVID, which is up from 1 in 20 last week. This is the highest infection rate in Canada right now. Leaked inpatient data shows that there continues to be over 1,000 COVID inpatients in hospital. It's now for 5 weeks in a row. It's been stubbornly stable, neither rising nor falling. Only 3 times have there been over 1,000 patients in hospital during the 5th, the 6th, and the 7th Omicron waves. It's been about a year since we've had this many patients in hospital. ICU topped out at 40 a few weeks ago. That's the highest since early January. Fortunately, that's far from the peak during the Delta wave. They remain with about 30 to 40 patients in ICU for the last 3 weeks. We're welcoming back. Oh, this is an exciting one. We always do our Twitter news media shout outs to folks who have really been helping get information out to Albertans that they desperately need. And so this week we're welcoming back Robson Fletcher, who started to do stats analysis again. He was invaluable during the first couple of years of the pandemic, before some very important paternity leave, which we all support. But it is really, really exciting to have his voice and his analysis back in the conversation, helping keep all of us and all of our neighbors safe. In great news from Calgary, the Rocky View General Hospital and the Peter Lougheed Centre have instituted mask mandates for staff, as well anyone who's in patient-facing positions within the hospital, which is great. The Foothills Medical Center, South Health Campus, and Alberta Children's Hospital do not have these in place. because apparently they have to wait until more people get sick from hospital-acquired infections before it's allowed. But publicly released data as of last Thursday, we had 18 deaths, and so that's 3 per day, which is down from the about 5 per day that we were facing last week. So I suppose that's a little bit of a silver lining, but still too many fellow Albertans to be saying goodbye to in a week from an illness that we know how to prevent. Um, but I'll take the 3 over the 5, I suppose. Today, we're going to spend some time talking about that system as a whole in terms of legislation, this ongoing conversation between private access to care, public access to care. I know for myself personally, our public healthcare system is truly the crown jewel of being Canadian. And it has been really challenging over the last few years to watch our system and our healthcare workers be decimated by policies that, to me anyway, seem so opposite of what it means to thrive as a Canadian and thrive as an Albertan. I'm going to bring up our panelists so they can introduce themselves. As we all know, I don't like to speak for people. If you have any questions while any of the presentations are happening or anything that doesn't get touched on that relates to that future of public healthcare in the province, please feel free to comment if you are on a platform that allows that to happen, and I will do my best to work them into the end of the conversation. Once again, from all of us at Protect Our Province, thank you so much for giving us your eyes and your ears again. And here we go, bringing up some folks. Hello, everyone. I have control to mute and it's just Chris. I don't know if I can unmute you. Oh, I was able to. Okay, perfect. That is fantastic. Excellent. So we will just go around, maybe starting with Chris and then going to Dr. Hardcastle and Dr. Mendings. If you could each just introduce yourselves, let us know what lens you're speaking from, and then we'll turn things over to Dr. Hardcastle to set our stage for our conversation today.
Absolutely. Chris Galloway, my pronouns are he, him. I'm the executive director at Friends of Medicare, joining you here in Treaty 6 from Edmonton, and from a kind of public perspective of advocacy on our healthcare system is what I'll be speaking on today.
I can't remember if I was supposed to go next. Yeah, I already forgot. I have the memory of a goldfish. I'm Lorianne Hardcastle. I am an associate professor, and my area of research is health law and policy. And the specific piece that I want to talk about today is really around the public, and the public versus private piece, and what that means. Because I think there's lots of confusion around definitions.
Well, I'm John Meddings. I'm honored to be with all three of you here today. I'm a gastroenterologist. I'm a physician, although I retired my clinical practice a year ago. I'm also the past dean of the Cummings School of Medicine, but I'm speaking totally on behalf of myself. The Cummings School of Medicine is probably wise not to own me anymore.
I personally prefer that, as it is hopefully will be largely unfiltered and infused with vast amounts of experience, as you are currently floating in a beautiful nebula that I wish I could be floating in. Thank you all again so very much for giving us your time today. Dr. Hardcastle, we're going to start things off with you for just a little bit of an overview, and then we'll move things over to Dr. Meddings, and then Chris, I am so happy to have you here. Friends of Medicare is very near and dear to my heart. You guys do such fantastic work. And so then I will bring you up as well to add anything that you feel needs to be shared from that advocacy / possibly missing perspective, because I know that your base of knowledge is exceptionally vast when it comes to how humans can advocate for their access, as well as what you guys are seeing in the system or potential pitfalls that could end up coming to bite us in the proverbial buttocks a year, 2, 3 years down the road. So I am going to move things over to Dr. Hardcastle. Thank you all again so much.
Great. Well, thank you, Michelle. So when we say private and private healthcare, I think there's a lot of misconceptions around what that means. And so I wanted to add some clarity there, which will hopefully then be able to move forward our conversation about what's actually happening in Alberta. And so the main distinction I want to draw is between private finance, or where you're paying privately to access healthcare services, versus private delivery. And what's happening in Alberta is a shift towards more private delivery. So the government, for example, contracting out surgeries to what they call chartered surgical facilities, which is relatively recent. Most of the conversation in Canada over many decades has been on private payment. So the idea of patients paying out of pocket to access healthcare services. And many of the listeners will be familiar with the Canada Health Act, which actually talks about this. It talks about provinces having an obligation to prevent these financial barriers to patients accessing hospital and physician services. What's interesting, though, is that the Canada Health Act doesn't make the provinces do anything. It just says, if you want these federal dollars, you will do this. And so it actually, the whole system is kind of held together by just really a thread, right? If a province decided that they would rather strike out on their own and allow private payment and forego that federal money, they could do that. It's a lot of money to leave on the table, but they could do that. And so it's important that we keep holding provincial policymakers' feet to the fire and saying, no, this is a system that we want to keep. And it's important when we're voting federally that we consider, who is saying they're going to keep all of this in place versus who is suggesting that we might reopen the Canada Health Act and allow provinces to experiment with private payment for care. And so the Canada Health Act kind of says, okay, provinces, if you want this money, you have to do this. And what the provinces do is they then have their own legislation that limits private payment. And they all do this differently. But the two big ways that Alberta does this is it doesn't allow for private insurance for services that are covered by the public system. So you can go out and buy private insurance for dental or for pharmaceuticals, but you can't buy private insurance for regular insured hospital and physician services. And then the other thing that Alberta does, which again, most provinces do, is it prohibits what's called extra billing. So it prohibits your doctor from both charging you a fee and billing the public system to see you. If your doctor is part of that public plan, then they can only bill the public system and that's all they get. They can't charge you on top of that. So that's the private payment piece. The argument that you sometimes hear people make is that, well, we should allow people to pay privately because that gets them off the wait list, right? If 10 people buy their knee replacements, that's 10 closer spaces I get to move up on that wait list. Unfortunately, that assumes that public and the private system aren't competing for the same pool of providers, which isn't true. The biggest issue with allowing people to pay to jump the queue is that often the people who can afford to jump the queue are in better health. And so we're, in essence, not only allowing those who can afford it to jump to the front of the line, but also oftentimes those are the healthier among us. And we can look at countries like Australia or the UK that have that kind of system where they have a universal public system, but then they also have a parallel private system. And we can look at those countries and we can look at how the regulators in those countries have sometimes struggled to address these issues. And for example, in the UK, to make sure that providers are spending sufficient time in that public system. So that's private payments. The other piece is private delivery. And so that's that contracting out. And, some people will say, well, there's always been private delivery. Your family doctor is private delivery. And that's true. But your family doctor, I think of them more like a small business where they're billing the government, they're bringing in revenue, they're paying their staff. But more recent legislative changes from a couple of years ago allow not only your family doctor to bill the government or your doctor to bill the government, but also allows for other entities like corporations to be that middleman where they're the ones billing the government and they're the ones hiring physicians. And there's concerns maybe with the influence that they would have on quality of care, how that corporatization of the practice of medicine might affect quality. And so you'll hear the government say over and over again, private delivery isn't problematic. You're not paying, we're paying. No one's paying for healthcare. It's all fine. There's nothing to see here. And well, it would be worse if we were paying. There are still concerns with private delivery, and these can be lumped into the categories of cost, access, and quality. And I think some of the other speakers might get into these, but I'll just introduce them briefly. So the quality concern is that if we allow these private for-profit operators, particularly corporate operators, that they need to generate a profit. And so the concern is that in order to maximize that profit, quality of care erodes. They maybe have fewer staff hours per patient, or they hire staff with lower qualifications. And we see this, for example, in the context of private for-profit nursing homes. The second concern is cost. And the cost issue is that these private facilities, so let's say a private surgical facility, they tend to treat the less complex cases because those cases can be more profitable, but also patients with really complex health needs may need to get treatment in a public hospital, may not be suitable for care in a chartered surgical facility. And so the cost issue is, if they're taking the cheap, easy cases, are we paying them accordingly? Does what they're being paid reflect the fact that they're taking these cheaper, easier cases? Because if it doesn't, then that's going to slowly drive up costs. And that's what we've seen when we've experimented in the past, let's say with private orthopedic delivery in Calgary. There's also a tendency to pass costs back off onto the public system wherever possible. And then sometimes we can also see a tendency to upcharge patients or to sell them things that aren't covered by insurance. And sometimes those things are medically necessary, but that's not always the case. And then the final concern with private delivery is access. If we have these chartered surgical facilities who are treating the less complex, healthier cases, and they're pulling health professionals away from public hospitals, then the concern is that the healthier, less complex people are receiving care sooner than those who might have more significant medical needs, who may be waiting longer in public hospitals for care. So as I said, I think some of our other speakers might get into those cost, access, and quality issues in greater depth. But I'll leave it there for now, Michelle, and I'll let you bring someone else into the chat.
Thank you so very much, and thank you very much for that overview. As I mentioned before, if anyone has any questions for our panelists as we continue this conversation, please feel free to pop them into the chat. John, I'm going to bring you up now, and we will momentarily say goodbye to Dr. Hardcastle. We have your slides ready for you. Feel free just to say next slide as you so desire us to change them. Thank you very much for joining us today.
So thanks, Michelle. And Lori, and I have to say that was a spectacular opening, and I'm going to spin off a few points that you brought up. And one of these issues is on this issue of private care. And just a simple fact, actually, that Canada as a healthcare system has second only to the US, the highest amount of money that we already spend on private care. Most people think we don't have private care, but dental care, pharma care, care for the elderly, home care, are all virtually private, actually, in Canada. That is not the case in most of the other OECD countries that do far better than us. The other excellent point that you brought up is that the one thing Canada does forbid is paying privately to physicians. And part of that, and I think you mentioned this, is the number of physicians that we have. And so I want to spend a little bit of time so that people understand a little bit about healthcare workers and how many we have. And please forgive me actually for saying this is going to be physician focused. It's what I know the most about. I suspect that many of the lessons that I'm going to cover here are true for nurses and other allied health workers. But let's just talk a little bit about number of docs. Do we have enough physicians in Alberta or in Canada? And I'm going to show you some data, but every time I think about data, I like to do a little bit of a back of the envelope calculation, a little sniff test, because data, the old Mark Twain statement, you have lies, you have damn lies, and then you have statistics. You can make anything look right if you present the data in the right way. So there's a simple set of questions that we could ask ourselves. And I think personally, being an older one, that I would have answered these questions very differently 30 years ago than I do now. And if you ask yourselves, do all people in Alberta have a family doc? Clearly not. When I started practice, clearly yes. What's your wait time to see a specialist if your family doc, if you're lucky enough to have one, sends you? As a specialist myself, our waiting lists were measured in years. When I started, it was days. And in fact, if your family doc had phoned me and convinced me that this was a real acute thing, I'd see you today. What is the wait time that you would have once you've seen a specialist for an operative or other procedure? And again, these numbers are ridiculous. And all of those answers suggest to me that we don't have enough. In fact, we have far from having enough providers. So the sniff test is we don't have enough, but how much of a difference is there? So could I have the next slide, Chad? So WHO has a wonderful data resource called the Health Observatory. It has a massive amount of data that's well worth perusing. One of them are the number of physicians by country, and they are measured as physicians per 100,000 patients, because obviously countries vary in size. And shown on the slide here are all the countries in the world, and they're color-coded, and the color goes from a light blue to a dark blue, and the range is from about 0.2 physicians per 100,000 to 84, so really a huge variation. And you can just very quickly see that Canada sits at a very pale blue. There's a lot of countries that have more physicians and a lot of countries that have less. I'd note, though, that the countries that have less are often those countries that we might consider third world countries. So next slide, Chad. What I've done here is I've cherry-picked a few countries that we might typically think of as having they're sort of peer countries to us. And I've changed the data to physicians per 1,000 rather than 100,000. You can see in red, Canada sits at about 2.4 physicians per 1,000. Australia, USA, Russia, Finland, Sweden, Norway, France, UK, New Zealand, Italy, Spain, all of these countries that we might think is pretty similar to ourselves have a heck of a lot more physicians. So in the UK, that has around 4 physicians per 1,000, it is not inconceivable to have a separate private service for medicine because, in fact, they have twice as many physicians as we do. So next slide. So has that always been the case? What I showed you was a snapshot in time, the latest data. And in fact, you can go to other sources of data and you can check how many physicians Canada has had in the past, going all the way back to the dawn of Medicare in 1978. And we've gone from about 1.9 physicians per 1,000 slowly up to about 2.4. And we're split roughly between 50% physician or specialists and 50% family physicians. Next slide. So we need more physicians. So how can we get them? One thing that is common to speak about right now are recruitment of foreign physicians. And I'm not going to spend a lot of time on this, but it's clearly possible because the rest of the world, most of the rest of similar countries in the world have more physicians than we do. But when I sit and think about this, we're a wealthy country. Do we really have the moral right to steal physicians from other countries? particularly when those countries already perceive that they don't have enough. And I think there's been a very salient example in South Africa. Canada and a few other countries, but mostly Canada, spent a lot of the end of last century recruiting South African physicians, and we decimated the healthcare system in that country. So I'm honestly not sure we're on a morally strong position by saying we'll simply ask other countries to train our own. So what about Canadians who study abroad? This is another issue that has come up. Could we bring them back? It's an interesting thought. We have 17 medical schools in Canada. We train about 3,000 physicians a year. I'm told, although I haven't seen the data, so I can't vouch for the reliability, that about 6,000 Canadian students leave the country every year. They train as physicians, and they actually do have difficulty in getting back. So is this an option? Next slide. I think it's worth thinking about. But in Canada, we have a very highly valued, publicly funded healthcare system. And I think two questions arise from that. Should the physicians that we have serving our population, should they be at least somewhat representative of those patients? And secondly, should the physician values be similar to our population values? And if you think about it, for example, our largest unmet need right now is rural primary care. So if we were to select physicians from a pool who are predominantly wealthy and live in urban centers, that is, from families that are wealthy enough to send their children abroad to study medicine, that may not be our best strategy to get people who are going to want to take a position in rural primary care. And secondly, if we truly do value a publicly funded healthcare system that is part of our Canadian value system, wouldn't it be smart to have some control over the values that physicians are taught and inculcated with during their training? So next slide. So what about training our own, and how well do we do on that? And I'm going to finish on a couple of slides here of data that has really sort of surprised me when I put it together today. How many physicians do we train? And the source of this data is the number of physicians that we train from an organization called AFMC, which is all of the Canadian medical schools, and Stats Canada for Canadian and provincial populations. So what is shown on this graph is the Canadian average. It's the number of physicians that Canada trains for every 1,000 population, done by year from about 1990 to 2021. And that's the latest that the data is available for. And this graph shows some really interesting, to me at least, findings. First of all, you can see in the early 1990s, there was a sudden drop across the country in the number of physicians that were trained. And this, to a large extent, was the result of a report called the Berer-Stoddard report. And the Berer and Stoddard report was the work of two health economists who were very smart, very bright. And I'll paraphrase a little bit. They said this much more eloquently than I did. But they pointed out the fact that healthcare systems cost a lot of money. And secondly, every dollar that is spent in a healthcare system, if you trace it back far enough, had a physician doing something or charging something to the system. So if you wanted, therefore, to reduce healthcare costs, you should reduce the number of physicians. And they found a very receptive audience in the deputy ministers of health across the country. And in the early 90s, all medical schools across the country had the number of students that they were training cut anywhere from 10 to 20%. Now, it takes 6 to 10 years to train physicians. So it took a while, but it was not at all surprising that in the early 2000s, we noted that we had a shortage of physicians. Now, to be fair, this was not all because of the Berer-Stoddard report. There were other things that happened at the same time. But the net result of this is that we had a significant reduction of physicians in the early 2000s. And we reversed that trend across the country, and numbers of medical students at medical schools went up until the mid-2010s, and things changed then. Next slide. This is the Canadian picture in blue. You can also take this data and look at individual provinces. And you can see that to a large extent, they parallel what happened in Canada, as you might expect. Some provinces, such as Ontario, despite being a big province with 5 medical schools, underperform the national average in the number of medical students per capita that they produce. And others, thank goodness, like Manitoba, overperform. What about Alberta? Next slide. Alberta is fascinating. It's shown in red. In the 1990s, we overproduced medical students per capita for the country. And I think that's fair. As Canada's wealthiest province, I think it is only fair that we should take on and shoulder a bigger load of training medical students. We lost students with the Barrist audit report, just like the rest of the country did, and we subsequently increased them. But around the time that oil prices tanked in the early 2000s, you can see once again there were massive cuts by governments in Alberta to the 2 medical schools, and the number of physicians dropped. That's something we have yet to recover from. It went back up again, but over the last decade, you can see that now Alberta has gone from being an overproducer of physicians to now being an underproducer of physicians. That to me is a bit shocking. This is, in fact, the wealthiest country, as I've mentioned, the wealthiest province in the country, and we are relying upon other provinces to fulfill our healthcare workers' needs when it comes to physicians. Now, most of that decline has in fact been because the population of Alberta has exploded in the last decade, and governments have not changed the number of students in medical school classes. So this is a case of not the numerator going down or going down, it's the denominator going up. Next slide. And this, in fact, is the end. So the conclusion of all of this is we don't have enough physicians to manage the healthcare system that we currently have. And in fact, if you were to say how much, it is roughly that Canada needs to double the number of physicians to come anywhere close to approaching peer country numbers. And I would point out that most of those peer countries are relatively small and have a high population density. It is harder to provide medical care when your population is geographically dispersed. So in fact, Canada probably doesn't need to just double, it might need to do a little bit more. Secondly, Alberta underperforms in MD training numbers compared to the rest of Canada. And so it's not at all surprising to me that we're feeling the stress right now of too few physicians. The solutions to this, I think, actually are not all that hard. In the short term, we absolutely should be looking at increased recruitment of Canadians studying abroad. I don't believe that that's a long-term solution, but with appropriate checks and balances, I think we could solve things quickly in the short term with that. I think we absolutely should be training our own, and we have to increase medical school enrollment. And finally, to help our primary care teams, we should be expanding their reach by providing them with allied health workers that work in close conjunction with our family medicine providers. And that's it for me, Michelle.
Thank you so very much. We talked a lot last week about the state of family medicine in Alberta, particularly the challenges that are facing primary care networks and primary care providers in terms of fee structures, managing their own small businesses, being able to maintain robust services and systems publicly for everybody. And so we talked a lot about losing doctors that are training in Alberta to other provinces that have been more forward thinking in terms of structuring their overall system for physicians to be able to live happy, healthy, more robust lives. And so it becomes doubly impactfully terrifying having this conversation, looking at the decline in Alberta's training and where we should be, whether or not we double or triple the number of humans we are providing access to medical education for, to shore up that system with that added compounded with the potential of losing people to other provinces that are homegrown as well, it does make me ongoingly concerned about what tomorrow brings, which I guess is why we're having this conversation, given that it is the future of public health care. So thank you so very much for that well thought out presentation. It was really fascinating to be able to look at the data points that you collected in terms of where we have been from that 1978 time period to now, and what has impacted the trajectory of practicing MDs within the country over the last 3 years. It's 2023, right? 1990. So thank you so very much. We'll bring you back into the conversation as we get into the conversation time period of things. I'm going to bring up Chris from Friends of Medicare right now. So Chris, we've had a little bit of legislative / contextualization of definitions, which for me as a regular non-medical human is always very important to me. We've had a look a little bit at the healthcare professional doctor perspective. And so what are your colleagues and your members feeling, saying, thinking about how we got here over the last decade to where we are now and where things might be headed?
Absolutely. And as a regular Albertan myself, I like the plain language, not medical acronym approach as well to what's happening in our healthcare system. And just before I dive in, I want to say, here we are again. This time last year, we saw a spike in COVID and respiratory illness that impacted our hospital capacity, impacted access, and that's really what I'm hearing from Albertans is they're concerned about access. But the point I wanted to make today is really around what that connection is, and what we heard from the last two speakers is we're really in a staffing crisis in our healthcare system. And I don't use the word crisis lightly. I think we are in a crisis situation. I don't know what else we would call it when hundreds of thousands of Albertans don't have a doctor, when every single day over 30 hospitals are facing closures, when surgeries are being delayed and canceled, when ER wait times are spiking, and so on. The staffing throughout the system is what's impacting us most. It's what's creating those issues. We have hardworking doctors, nurses, other healthcare professionals trying to keep the system going, working overtime, working forced overtime, working short. There's closures. Really, it's not sustainable where we're at. We're already unable to provide the care where and when we should, let alone looking ahead to some of those graphs we saw of what we need to keep the healthcare system going and available for Albertans for the care they need. So that's why at Friends of Medicare, for many years now, we've been calling increasingly desperately for the provincial government to create a workforce plan for healthcare. We really need a government laser focused on looking at the frontline workforce in healthcare, whether it's doctors or other professionals in the system, and really map out what do we need, where are we at, and what do we need going forward. And we're not seeing that work happen. We should be looking at a workforce strategy that includes retention, recruitment, and training, those key pillars that John already talked about, of how do we keep who we have here, recruit people into the system, and train who we need going forward. Instead, we're seeing these one-off announcements that aren't connected to any strategy or looking at the impact of what it might change throughout the system. It's just looking at one narrow indicator. And we're also seeing other provinces, similar to countries thinking about doctors, we're seeing other provinces do this work, like BC, who are actively recruiting our doctors and our nurses and our paramedics and other workers to move to their province, and other jurisdictions are doing this as well. So we're fighting each other in Canada for a limited pool of workers rather than planning out what we need and actually retaining and training what we need here in Alberta. So it's a very concerning situation. But the other piece I wanted to mention, which connects back to Lori and how she started us off, is instead of doing that work, what we're seeing is our provincial government is blowing up Alberta Health Services and our healthcare system, creating chaos, creating uncertainty, which won't help with staffing. It won't help with retention or recruiting people into the system as we move for this period of chaos. But more concerning to us is that we believe it's cover for even further privatization in the system. There's that old adage, you break it and then you privatize it. So really, this government has been doing that since being elected. They're allowing chaos to take hold, and then they're privatizing off pieces of the system, whether that was the failed deal with Dynalife, the private surgical centers that have been mentioned, home care. There's even in the documents that were leaked, from the cabinet on this restructuring, the idea of selling off our public continuing care homes. So that is the agenda we're seeing in front of us. It's been full steam ahead since this UCP government got elected. And we think the combination of the staffing crisis, creating concerns around access, and then blowing up the whole system with restructuring and contracts and chaos is really covered to just accelerate that privatization agenda and really move it forward even quicker than they already have been. And the using of that distinction of they love to talk about it's publicly financed, privately delivered, like Lorraine was talking about, as though it's no big deal. It's still, you're not going to pay to access it. It's fine, but it's not fine. It's making the staffing situation worse. There's no clearer example of that than the surgical centers that have pulled staff out of our hospitals. That's well documented. So we're actually getting fewer surgeries done than we used to while paying for-profit operators to do more surgeries. And that's happening throughout the system. So we're very worried about where we're at right now with healthcare, both in that we're not preventing the capacity issues in our hospitals, but also we're not actually looking at resolving the staffing situation for doctors and for everyone in healthcare. And there's really the government's agenda is privatization and ignoring the real issues in the system. So that's where we're coming at it from. For us, it's about access to public healthcare for Albertans, and our government doesn't seem to be focused on that. So those are some of the things I wanted to touch on, but also I know we want to hear from folks with questions on that. So I'll leave it at that.
Thank you so very much, Chris. I just realized as you were speaking that I have had the benefit over the last 2.5 years of being familiar with your organization, whereas some of the folks at home might not. So it seems to me that now would be an excellent time for me to ask you just to give us a brief little overview of the society, of your existence, a couple of the wonderful milestones, possibly, just because I'm coming from a privileged place of being like, yay, Friends of Medicare. And I would love for others to be able to say, yay, Friends of Medicare as well.
Absolutely. And sometimes people think we like sell insurance or something. That is not us at all. We're a nonprofit based here in Alberta. We're nonpartisan. We do advocacy work on public healthcare. Our goal is to protect and strengthen public healthcare for everyone. And we've been around since 1979 doing that work. And that year was important in terms of fighting the double billing and fighting for the Canada Health Act, that milestone. But over the years, we've been part of all sorts of different fights. And it's often a fight to, there's always those who want to profit off of our healthcare. And we're always there pushing for that public good, that it's universal for everyone. So when Ralph Klein was in power and pushing that third way agenda throughout the years, we've been there fighting back and fighting for stronger public health care, whether it's programs like the insulin pump program that we fought for and got and then recently protected, or the bigger system issues around staffing, around public hospitals, public surgeries, and so on. So that's the work we've been doing for decades here in Alberta, and it's the work that's done because of our members and volunteers who care a lot about healthcare as citizens of the province.
Thank you so very much. Website?
Friendsofmedicare.org.
Thank you. I'm going to bring our other two panelists back up into the conversation, and I think I will kick things off with a question. Again, if anyone has any, please feel free to write them into the comment section. I'm scared, which I feel like is fair, but I don't want it to all be about that. So I would love from each of you a spot that, as an Albertan, you would like to draw my attention to, be aware of over the coming, 6 months, 7 months, that might be quite concerning, and a spot for optimism as we dive through all of these things. I often take optimism in just knowing that people actually want to watch these conversations and have them. So maybe that's your optimism too. I'm not sure. But there's so much information and there's so much happening, whether or not we're looking at like maps and looking at the siloing of things, or whether or not we're looking at, potentials for new legislation or what may be introduced. There are so many things. So from each of your lenses as experts in your respective fields, as well as citizens of what I know is a province full of amazing humans, what are some of those, a more key point on either side that you really want to raise some added awareness around? And maybe we'll just go, we strive for open conversation. So I will leave it to the three of you to have that bit of a conversation. I don't believe in being like, and now you speak. And feel free to build off of each other as well. So yeah, a concern to watch for, something that's got your spidey senses really up and rattled, and maybe something that could shine a little bit of hope.
I can
Well,
certainly go if you want. Oh, go ahead, Lorian.
no,
You
no.
go.
I think, and John, you may be about to say the same thing. I think the thing that I'm watching is what this reorganization of Alberta Health Services looks like. So we're going to have the creation of these 4 new structures that each have part of the healthcare system, and an integration council and local councils, and there's going to be a new procurement secretariat and government. And so one thing I'm watching for is really how that all goes down. And I think there's a lot of potential concern. But I do think there are pieces that maybe we could be a little bit optimistic about, like the creation of an entity that's focused in on primary care, which maybe isn't something that we've had in the past. But I worry about patients falling through the cracks between these organizations. And then I also worry about health professionals being either deterred from coming to or staying in Alberta because of the chaos, and also just using up valuable potential patient care hours on learning new systems, trying to navigate new things. So yeah, I'll leave it there, and I'll let someone else chime in on their areas of worry.
You want me to go, Chris?
Sure.
So I'll add to that. And I am usually an optimist. I'm usually a glass half full person. And so let me be optimistic to start with. I'll end on a somewhat non-optimistic note, perhaps. When I look across the country in Canada, Alberta has been unbelievably lucky in many ways. We have the best healthcare system of any of the provinces. AHS truly was a marvel. It standardized, it centralized, it coordinated. It had embedded research in the strategic clinical networks that led to better practices everywhere across the province. So while we are going through some tough times right now, and we can very easily point to BC at recruiting our docs with a much better way of paying primary care physicians, or than Saskatchewan with their very fumbled attempts at trying to replicate the AHS structure. We actually have a long way to fall before we're going to drop down to some of the other levels. That's the good part. Now, I don't want to see us fall at all. I worry very much about the reorganization, not so much that it's necessarily or intrinsically bad. I mean, I think you can probably design multiple organizations to do the same thing, and some are going to be slightly better than others and others won't. What I'm more worried about is that it is not the problem. The organization of AHS is not what is causing us troubles right now. And so wasting time focusing on a reorganization when our real problem is inadequate numbers of healthcare providers, either retention, training, or integration, I think is a huge issue. I'd actually agree with you on the primary care organization, Warren. I think that is one area where AHS actually has never had anything to do with primary care. It has been a source of friction and confusion, how community care and AHS work together. And AHS, I would say, despite all the many things I love about AHS, they were perhaps not the most community-friendly organization you would ever imagine. There was a bit of friction there. So I think there is some opportunity with the primary care organization. I just don't think we should be doing it now. We should be fixing the problems that are staring us in the face, and then we should have talked about a reorganization.
Absolutely. To leap off of what both of you said, the reorganization to us, it's ignoring the problem in front of us to say you're doing something over here. So we're, for us, we're concerned what it's going to mean for staffing, for privatization, and for the patient experience, right? How are you accessing care? Who's responsible for you ultimately when you're accessing different services? Are you going to be passed around with no one ultimately accountable to ensure you get the care you need? So it's concerning. That I think is our reason for concern in front of us right now is why is the government doing it and what are the impacts going to be? In terms of optimism, this fall I toured the whole province pretty much. I've been all over the place. I've even been going door to door on pharmacare and dental care and some other issues where there's some action happening at the federal level on dental care for children and others hopefully soon. There's some talk on pharmacare. We'll see where that ends up. But going door to door, just cold knocking South Calgary or Edmonton or wherever we are, the response is always strong public support for public healthcare. They want public healthcare delivered by the public, universal to everyone. They're worried about it right now, and they're like keen to see good things happen. They're keen to push for things like pharmacare or dental care. So the public is still with us, even at this time where access is such a concern for people, where they may not have a family doctor, or they may have just spent all night in the stallery waiting to see someone. Even in that context, the idea for public healthcare is still so strong from just people I talk to in the public. So that gives me optimism that there's support there to solve these issues if we could actually focus on solving them rather than whatever is happening right now with this restructuring kind of distraction approach.
Someone asked a question really similar to what I was about to ask in follow-up to the comments that just came out. So any idea as to why this desire to restructure or dismantle or deconstruct or whatever words one wishes to use now? Because Chris, everyone that I know echoes a lot of those thoughts that you heard in door-to-door-ness. I feel like the majority of Albertans are very in support of public healthcare system. Their concerns would be around, wanting to expand that or have it function more efficiently with less complication. And everything that I have heard about proposals and potential things that are coming down the pipe feels to me like added layers of complication versus increasing my access to a system that I value and love as a taxpayer in this province. I know that no one really probably has an answer for this, as none of us are in the legislature's minds, but I'd be curious to know what all of your takes are as to why we are creating potentially way more damage and problems versus addressing some of those underlying foundational concerns.
I certainly have a thought, Michelle. And I think Andre Picard, the health reporter for the Globe and Mail, captured it well. This was not a reorganization. This was revenge. This was something that was promised, was to dismantle and to make AHS a minor player in a system that it used to be the major player in. So I don't think it was well thought out at all. I think this is what we're seeing. And I think the unfortunate thing, it is coupled to a very strong desire on the part of this government not to listen to experts. So you are going to make a dismantling take place, and what you're going to put back is going to be something, but it can't be what the experts say. And I think that's the mess we're in.
Yeah, I would agree. It's very much a political decision. AHS became a target for the premier, so she had to do something about it to show that. But they also are doing it under this guise of local control. I've heard that when out in, Medicine Hat or places that, people used to have a health board, and there's things that they saw that were good about that. They felt they had more, connection, whatever it might be. And so the government's kind of selling this as like bringing back some rural local input. But they didn't actually do that in the announcement.
No.
Like they're tweaking advisory councils and creating an Indigenous council. They're not governing bodies. They're not actually going to be making healthcare decisions in those communities. So they're kind of like falsely selling part of the reason they're doing this to people to try to get support, which isn't actually what they announced.
Can I just jump in, Michelle? I'm sorry, Lauren. So just to follow up on that, though, Chris, though, I think that's a very telling point. When you go back in the history and you look at the original regions, the reason that AHS came into place was one of the major complaints was that places like Medicine Hat and Lethbridge could not speak to the Calgary or Capital Health region and get their patients in. They didn't have enough of a voice, and so we created a single healthcare system. So it seems a little hypocritical to me to now say we need the regional voice. We're going to go back to what didn't work.
Yeah, I agree with both of you. I do think this decision is political. I think that there's AHS became a convenient scapegoat for the government during COVID. We saw when Open for Summer failed and the hospitals were just bursting at the seams, and the government was unwilling to bring back restrictions, was unwilling to go the route of what they then didn't call vaccine passports in Alberta. And they just expected hospitals to find more and more and more beds. But it's a two-sided equation. It's the hospitals, but government has to do things to prevent that demand for beds. And they weren't willing to. And so I think that Premier Smith, whose voting base has a large number of very anti-public health restriction people, AHS is a convenient scapegoat, because she can just say, well, they didn't do enough. Not that we should have had more restrictions or we should have done more about COVID, but just AHS didn't do enough. And they became a scapegoat. And, as you know, they were replaced. Their board was replaced with an administrator. And so I think in some ways, this is just following through. I also think that this is a government that wants a centralization of power in their own hands. They are probably right now in the Legislative Assembly debating a bill that will pull public health decision-making authority in an emergency into the hands of cabinet. They issued directives to the College of Physicians and Surgeons that during COVID that weren't typical. And I think that this AHS thing is also going to be a pulling of authority back into government's hands. I think they think that AHS has too much independence, is doing too much in the way of budgeting and policy making, and that's control that they want for themselves. So I think there's a few different things going on.
All of those statements definitely resonate with everybody tuning in on their various platforms. There's been a couple of requests for us to deepen the conversation around revenge. I know that word struck truly with, yes, it feels like it does. I have constantly felt over the last few years like I am under attack from my government. One thing that I wanted to clarify before I go into our final question and final statements was there had been a comment earlier on, and just we briefly touched on it, but then didn't. Sorry, I'm scrolling through to find it again, but didn't necessarily dive into it in the detail that maybe could have been beneficial to some folks. Essentially, it was a comment around often there is not enough OR time allocated for doctors just due to capacity issues within our care facilities. Would not opening up private facilities allow for that versus pulling them out of the system? My understanding of this issue is that it's not just the doctors, it is the OR nurses, the anesthesiologists, the support staff that make all of that happen. And that's where a lot of the impossibility of double dipping would occur in terms of this particular. Can you guys see the comment that Chad popped up for us? Yes. And so I was making the assumption that because of that overlapping of like how an operating room works, that's where we would be losing public sector workers into the private sector, which would create an even larger backlog. But I wanted to make sure that I don't like to assume or presume anything, that I wasn't misinterpreting that. So if anyone wants to speak to that, that would be fantastic.
John, you're the only one of us that's been in an actual hospital treating patients. So why don't you take a whirl at this first?
So I can start, but this is a really complicated question, Michelle, to be honest. So, and I may draw the ire of my panel compatriots here a little bit, because I don't think it is black and white, to be honest. I sort of mentioned before, in Canada, we spend about 35 cents on the healthcare dollar privately. That's the OECD average is about 25 cents. So we spend, in fact, more privately right now than most other countries. The thing that we don't do, in my opinion, is we do not use those private dollars wisely. We do not use them for competition. They are sequestered into little areas where this is basically all private. And so you cannot get what a lot of people call for, which is for private dollars to help make the public dollar system more efficient. Now, I'm honestly not sure that that's not just a fallacious argument to begin with, and there could be a lot of discussion about it. If we go to the operating rooms, we have lots of operating rooms in the province. Most do not run 24 hours a day. They're closed. So why is that? We have lots of operating room time. What we don't have are dollars provided by government or staff to run them 24 hours a day. That's a choice. That's actually government's choice not to do those surgeries. It's not that we can't do them. The flip side is that an operating room is not an operating room is not an operating room. One of the reasons that cataract surgery is probably more efficient done by private providers is that their operating rooms are set up to only do cataract surgery. If you go to the Foothills Hospital and look at the operating rooms, they're general purpose. They can do a lot of things, but they're not streamlined for one specific thing. So I'm a bit agnostic about it. I take Lorian's definition. When I go and get healthcare, I want to pay with my Alberta health card. I don't want to pull out my Visa card. I don't think that's where we want to go. But there can be some times where selective use of private providers would make some sense. But at the end of the day, right now, we aren't even maximizing the public system for what it can do. And I think that's going to be the first thing we should get ahead to do. So if you want to do more operating rooms, it's not talking about private providers. It's actually a government should be funding the public system to run 24 hours a day and operate.
Yeah, just to leap off of that for a second, it's like kind of that case of like, we tried nothing and it didn't work, so we have to try something else, right? Like we have these operating rooms, but as we all know, a bed is just a bed and a room is just a room unless you staff it, right? And at this time when we're already struggling with health human resources, to open a private surgical center instead of staffing the rooms we have, all we did is pull surgeons and anesthesiologists and nurses and others out of the public system to go to these facilities. And then we're seeing surgeries canceled in public ORs because they don't have an anesthesiologist there to do it, or they're being rerouted. So we ignored staffing and did this. And just in terms of these centers, there a lot of them aren't great actors in the healthcare world. They allow for queue jumping from other provinces as people pay directly. They cost more. We saw in Ontario, they're paying way more per surgery. They have secret contracts we don't get to see with guaranteed volumes, meaning actually the public, it's now in our interest to send staff there to do the surgeries we're paying for either way, rather than keeping our public operating rooms open. So there's a lot of issues with bringing these in, especially in this ideological way that wasn't really around wait times or getting surgeries done. So we have a lot of concerns about spending our money in that way when we do have operating rooms that we're not staffing and using to a full capacity. So, it's a choice. The government made a choice. It wasn't a strategy.
Thank you very much, Dr. Hardcastle. Anything that you wanted to add on that?
Yeah. So couple of thoughts. I mean, I don't think we can be completely dismissive of this idea that there are doctors who are saying, I could work exactly the same amount of time I'm working in the public system right now and, treat private patients. I don't think we can completely dismiss that. That said, if we looked at jurisdictions where that's allowed, they've had difficulty regulating and monitoring and making sure that doctors fulfill their obligations in the public system before treating those private patients. So, for example, if we look to the UK, they have trouble. You're supposed to spend 90% of your time treating public patients is the contract, and they've had trouble monitoring and enforcing that. And this issue was also discussed in a BC case where this issue of can we limit private care went to the BC courts, and the judge in that case, who heard evidence from around the experts around the world, said that some surgeons have some excess capacity, but he said that this is not sustainable unused capacity that we can rely on as a long-term solution. and it comes potentially at an equity cost if it's being used to prioritize those kind of patients with easier health needs. And so, the weighing of the factors was that, yes, maybe some of these rules that we have might prevent that capacity from being used at 100%, but the concerns that it would raise, that the trade-off weighs in favor of some of those concerns around equitable access.
Can I just add quickly, Michelle, and I won't take long. I think this is a huge can of worms. I've advocated with some of our orthopedic surgeon colleagues who are here in Calgary who have 1/2 day of operating room time a month. Now, an orthopedic surgeon needs to operate. There is no shortage of hips and knees to be done. Are you telling me that we're fully employing an orthopedic surgeon a 1/2 day a month? To me, it is ridiculous. So it's not as if we don't need them. We need more of them, but we are already undersupplying the resources that those specialists need to get their jobs done.
Thank you. And I really, it was very reawakening for you to raise the point before, Dr. Beddings, around some of them have time. We do have the facilities. There has been a choice within the structure to not fund that space to happen. So even before we look at creating more spaces, moving things over here, doing this, that, or the other thing, again, we've had a lot of comments in the chat around the lack of the openings and the space within our current system that could be better leveraged to create happier, healthier access to care for Albertans.
Yeah.
One thing that has come up continuously, and so it is where I will leave us. I'm not an expert, so maybe the government will hear what I have to say. How do I tell them? So from all of your guys' lens, what support can Albertans be offering to advocate for an ongoing public system? So, and same with that ongoing support of like your colleagues, John, I think Albertans are keenly aware of how challenging these last few years have been on all of our healthcare providers and allied health professionals. And we value them and we value a public system. And so any activism, action, and or supportive points you can give people at home before we say goodbye. And it's just an open forum.
Well, I mean, I think that there are things that are not a done deal, that there's still space to try to push the government on. They've announced the broad brush changes to AHS, but there is still room for people to influence the details of what that looks like, and to push the government to deal with some of the concerns that people have around the reorg. For another example would be that the government has announced that it's going to bring in legislation that would allow, they call it compassionate care legislation, but it would allow for the compelled treatment of individuals struggling with addiction. That's not a done deal. There's still, that legislation has not been tabled. There's still room for advocacy there. We know for a long time that the government has said that they're going to bring in changes to continuing care legislation. That is not a done deal yet. There's still room to advocate. Once the government has announced something or has tabled a bill, at that point it becomes difficult to persuade them to make changes. But there are a number of important topics where general announcements have been made, but there's still room to try to move the needle by pushing back and by making your voices known to your representatives.
So Michelle, I am not an expert in this, so this is something I don't know about. So I'm interested in Chris's comment. But it seems to me that having worked in sort of leadership or administrative roles, the last thing I used to want to hear was having made a decision, having my telephone ring incessantly, my email inbox dinging, and people writing constantly that I had done a really dumb and stupid thing. That's the last thing that I would want to have. So it strikes me that the voices, our government is not going to listen to expert voices. My voice is useless in all of this. But if people in the general public were to be calling their representative incessantly, writing them incessantly, organizing others to do the same thing, that they might at some point get tired of that and actually start listening.
Yeah, to leap off of that, first I would say go to friendsofmedicare.org. There's ways to get involved and take action on that wonderful website. But I think people sometimes forget, like, we do have more power than we think in this scenario. And it's like John was just talking about, this government, as much as they're stubborn, and we've used words like revenge uh, tonight, and they're kind of the hostile to experts if it's not what they want to hear. They also do get annoyed and eventually react. We saw with EMS red alerts, the incessant media coverage and the coverage of that. Eventually, they announced they were going to do things about it, and even if we didn't like all the things, they finally got worn down enough. And with the privatization of labs to Dynalife, it just became such an annoying issue that they've now taken that back into the public system. That wasn't an ideological choice on their part. It was like, oh my God, this has to go away. We're finally just going to do that, right? And we saw that with insulin pumps. They announced cutting the program, and immediately UCPMLAs heard from thousands of people saying, absolutely not. How are you doing that? And they back down on that. So there are moments where we can push, or issues we can push, that even this stubborn government will react to. And just the last thing I would say, to doctors and other healthcare workers, you actually have a lot of power in this scenario, and Albertans are willing to support you if you use your voices. And we're heading into a lot of bargaining next year for healthcare workers, and they might want to think about that in terms of what they're pushing for and the public support that could be garnered for what they're pushing for. Because we've seen places like BC get really good contracts for nurses that include staff patient ratios and other structural things, right? So I think if you're a healthcare worker watching, think about the year ahead and what you're pushing for and how we can support you in that, because you have a lot of influence on the system. So I'll leave it at that. And friendsofmedicare.org, that was the website. Well, look, there it is.
Chad made you a banner. Thank you all so very much. And thank you very much for that note, Chris. Yeah, the HSAA red alert EMS stuff, yes, and and the insulin pumps, and Dynalife still may have some signs up, but we know ideally that will. It's been a challenging enough few years that I think it is easy to forget the victories, because it always feels like there's so much more to fight. And those are 3 really good victories. And so that actually, thank you. I feel like not all hope is lost. And I feel like that every week that we manage to get together. Thank the 3 of you so very, very much for your time. A huge thanks to the behind the scenes team at Pop AB for these pop-ups, and to everybody who joined us over the last 3 weeks. That is a huge inspiration for me and reminds me as to why I love Alberta, even when I want to smack its legislative buttocks. Thank you so much. Pop AB is not going away, but this was the end of our little pop-up series. We will pop up as needed. You are all wonderful. Have an excellent December, whatever holidays you celebrate or don't. And until next time, stay safe, Alberta.